So our next speaker is Dr. Nivez Rasic. She's a duly trained FRCPC pediatric anesthesiologist and pain medicine specialist and an associate professor in the Department of Anesthesiology, Perioperative and Pain Medicine at the University of Calgary. She's a researcher and educator who also serves as the acute pain lead on the Alberta Pain Strategy. She's been focused on improving care for individuals having surgery, which includes evidence-based use of opioids as part of multimodal analgesia and the development of a transitional pain service in Alberta. Her clinical work involves providing anesthesia for children and managing acute and complex chronic pain in youth. She was a Mayday Fellow in 2020 to 2021, and she's going to share with us the launch of a transitional pain service in Alberta. So thank you, Dr. Rasic.
Thank you for that introduction. I just want to start out by thanking Hans for the invitation to come to Toronto to present to you today and to come to this actually wonderful conference. I've learned a lot, and it's been really great to have all these different perspectives and experts in their field share all this really important information to try and drive this field forward. So it's actually been a really wonderful day. Thank you. Hans is also a collaborator on some of the work that I'm going to present, as well as some other folks in this room, Joel, Brittany, just such a fabulous team, so I'm excited to share some of that work. Perfect, it works. So I think I'm just going to take a minute to talk a little bit about the landscape in Alberta. Where we are, how we're trying to drive this field forward. And I just want to fully acknowledge that, we're taking a lot of our direction from all of the efforts by Hans and his team in starting the transitional pain. You guys really are the trailblazers, and we're trailing behind, but we're trying to sort of keep up, and we're trying to design something which fits kind of where we're at based on some of the provincial factors that are going on and our ever-changing healthcare system, which I know you're hearing about in the news. So we're just trying to sort of see where you're at, see what you've developed, and try and adapt that to our context for something that would work for our population. Some of the catalysts that have allowed us to achieve as much as we have, one of the main ones was the development of the Alberta Pain Strategy, which now is almost nearing its first 5 years. And this really was an effort by one of our colleagues, John Pereira, who I'm sure a lot of you know. He's the president of CPS currently, and he had a meeting with the head of the Strategic Clinical Networks of Alberta Health Services. This was back in 2017. And really implored on her the importance of pain, how it's siloed, undermanaged, poorly managed, and really we need a unifying provincial body to be able to advocate for this patient population and be able to drive this work forward. And it was that meeting that really launched the Alberta Pain Strategy. And so Tracy Wasiluk, took on that challenge, and together we had over 300 stakeholders that were involved, several meetings to develop the Alberta Pain Strategy. And we wrote that document, and we were very happy when it was finished and we had endorsement from all these various organizations within Alberta. And within it, we endorsed the biopsychosocial and also spiritual components of pain. We realized that pain affects all ages, across the lifespan, across the continuum of care. And really, it's just sort of a blueprint for how we should be managing and tackling pain in our province. And as I mentioned, this journey began, I think it was sometime in mid-2017, and here we are in 2024, where we're now meeting to try and envision what the next 5 years look like and where we should go from there. We've achieved a lot in the last 5 years, but as we all know on this journey, it feels like every time you achieve something, there's all these further milestones that we need to achieve, and the needs are there, and we just need to keep adapting. I've been focused largely on the acute pain side of the strategy. So there was an acute pain side, chronic pain side, and then an opioid-specific piece of work within that strategy. And I've had a specific interest with pain and surgery, just given my background as an anesthesiologist. And ultimately, as we all know, there's so much to consider when we think about an individual as they embark on their surgical journey. This problem is complex, and we need to consider all of the biological, psychological, and social factors that are involved in someone's pain experience, but also the surgical factors and the healthcare system factors. And then we throw in the pharmacologic management of pain, opioids into this mix, the illicit supply, all the other things, and all of a sudden I feel like that's what we have is this ball of yarn that we're trying to untangle and try and sort out. And when we were thinking about this problem a few years ago, we sort of tried to pick out some pieces that we thought we could address and tackle in this big, complicated problem. And one of the things that I know when I speak with colleagues who are in this area of work, if we were able to identify those individuals pre-operatively who we knew would have a difficult course through their surgical journey, and be able to provide them additional service, bolster the care that they're getting to try and mitigate the development of chronic pain, that would be a huge win. So that was one of the areas we thought would be a reasonable place to focus. The other thing, and I know this was presented earlier by Sanjo, we know what best evidence prescribing practices are for acute pain within surgery, but where we fall down is in the implementation phase, and Sanjo did a great job in North York Hospital with that, and we in Alberta, quite frankly, had a huge way to go. It was all disparate, all over the place in terms of how post-op pain is managed throughout the various surgical services in the province. Third area we also wanted to look at was looking at technology. How can we use technology to try and help this huge problem? And then fourthly, we needed to better support this population, this large population of patients who are struggling with high pain before and after surgery to improve their functional outcomes and decrease healthcare utilization overall. So then SUAP came along, which is a fabulous opportunity for us to put all of these thoughts down on paper and apply for this grant. And the 4 objectives that we have, my presentation is really based on this. This is how we discussed it every single Monday morning at 9 o'clock. We went through each objective and how we were doing in terms of our progress. We applied for a grant, and we were so fortunate to receive it. And our grant went on for 18 months. It just expired on March 31st, 2024. And I'm just going to go through some of the work that we were able to achieve in the last 18 months. So objective number 1, which we affectionately call it, was trying to develop a CPSP screening tool. And I think we all know this data. Chronic post-surgical pain affects a whole lot of patients. It depends on a whole bunch of different factors, including the surgery type. And as I mentioned, we really would like to be able to identify this patient population ahead of time. So again, putting our heads together as our team, the first step we needed to undertake was to do a review to determine what are the main pre-surgical risk factors involved in the development of CPSP across all surgery types. This was an absolute massive undertaking. So we ended up doing an umbrella review. An umbrella review, for those of you who don't know, is a review of reviews. So a review of the systematic reviews, scoping reviews, and meta-analyses out there. It was led by Beate Sidora, who did an absolute fabulous job of managing the team and this massive volume of information. We searched 6 different databases and ended up with 2,344 articles. After many sort of iterations, et cetera, we trimmed this down. The studies that were included in this review were 36 systematic / scoping reviews and meta-analyses for inclusion and analysis. After a year of work, we found that there were 39 main risk factors involved in these 36 reviews. And we grouped them in 5 different categories: psychological factors, health-related factors, pain factors, demographic, and social lifestyle factors. These risk factors came from a variety of surgeries: orthopedic, spine, thoracic, breast surgeries, and they were defined by 106 different tools and questionnaires in addition to the demographic and lifestyle descriptors. I realize this table is a little bit difficult to read, but I just want to highlight all 39 risk factors in a table. And the strength of evidence is noted by the colors, and dark blue indicates the highest strength of evidence. In terms of the conclusions from this adult umbrella review, this is, I'm sure, not a surprise to most people in this room, the most consistent predictors of CPSP are in the area of mental health. Anxiety and depression were very strong. Also, somatization, pain catastrophizing, and a couple of others. Higher pain at the surgical site preoperatively was reported as a risk factor across most surgical types. Comorbidities also, this was often represented as a single discrete variable present or absent, but a variety of comorbidities is a risk factor for the development of CPSP. And then other factors, they were not extensively studied, but when they were strong risk factors, were socioeconomic status, lower income, and poor job satisfaction. Age was interesting, so if you were a female having breast cancer surgery and younger, that was higher risk. Otherwise, being older was higher risk, things like spine surgery and arthroplasty surgery, and female sex was identified as a risk factor in 7 reviews. So now that we have this information from the umbrella review, there's different ways that we can go ahead and develop a tool. Again, putting our heads together, trying to think about methodologically, how could we best do this? Using an existing database of patients was really, and then we could use big data, was felt to be the best way to go forward. And we were able to collaborate with Hans Clark. He has an existing cardiothoracic database of patients. We looked at the umbrella review. We looked at the data that was collected within his database. It didn't exactly match up, but we did our best to pick out the risk factors that we felt would really the strongest predictors of CPSP. And Dr. Andrew Walker at the University of Calgary did the statistical analysis. He employed lasso regression to determine which risk factors were the most important in this sample. And through some very fancy statistics, please don't ask me any questions about this, I'll refer you to Andrew. He did lasso regression and identified 5 variables that generated the lowest cross-validation prediction error for chronic pain, which were age, sex, presence of preoperative chronic pain, somatization score, which has an association with anxiety and depression, and the HADS-D score. The next step for this tool is to validate it. And so this is kind of the next piece of work that we'd be looking to do. And again, for us, ideally, if we could have another database with a different surgical population, I think would be an ideal way for us to validate this tool. So I'm going to present you a little bit of the work that was done to develop a pediatric CPSP screening tool. And this work has been led by Brittany. She's done an amazing job. When it comes to pediatric literature, this study was published in 2017, and it was I'd say it's like a landmark paper. And it was a review, it was a prevalence and predictors of chronic post-surgical pain in children. And in this systematic review, there were only 4 papers, and I think it was just over 600 patients. From these 4 papers, the data showed that 20% of children and youth who have major surgery will go on to develop CPSP. This was really a huge piece of information for those of us who work in the pediatric pain and surgery space. So this was done in 2017. Here we were in 2023 or 2022, and it was time to redo this review. So these were the inclusion and exclusion criteria to update this review. And in the latest systematic review, there were 20 studies that were analyzed. as opposed to 4. So the literature has definitely expanded over the last 6 or 7 years. And with this latest data, the number's actually gone up. So the rate of CPSP for children and adolescents is up to 28%. It's absolutely shocking, actually, to me, who works and gives anesthetics to children on a daily basis, that this is the rate of development of CPSP. Again, probably no surprise to those of you in the audience as you work in this space, but the risk factors that are most important in terms of predicting the development of CPSP are psychological, both for children and for their parents. Brittany and her team are busy developing a measure, which she's named the pain risk measure. And again, in terms of the methodology to develop this, it started with a systematic review. There's not a large database of surgical children to use, so the methodology obviously has to be somewhat different. And when she looks at the risk factors that are important in the development of CPSP for children, there were over 200 items in total for children and parents. So within the second phase of the development of this tool, there's a Delphi. The first Delphi is just finished, like literally, yesterday or this week. And Brittany's going to compile this data. And this Delphi procedure is there to refine the risk factor constructs in initial item pool, probably to be followed by a second Delphi, et cetera. But the pain risk measure is coming. So stay tuned. So that was objective number 1. That was a lot of work. Objective number 2 really was focused on improving pharmacologic opioid management for patients in the post-operative inpatient phase. And this work was led by Keila Dines, who did she's an acute pain service nurse at one of the adult hospitals. She's done an absolutely fabulous job of this work. We know that poorly managed acute pain increases CPSP risk. Opioid prescribing after surgery at Alberta hospitals, quite frankly, is all over the place, and there's need for consistency, safety, and evidence-based prescribing. So we did get Epic Connect Care right in the middle of the pandemic, which was, a journey. But here we are, we have it, and this new information system presents the opportunity to implement province-wide standardized opioid analgesic prescribing. And so we developed, again, a large multidisciplinary provincial working group. It was represented by a whole bunch of different areas in medicine, and we created, again, this is based on a lot of the consensus that we've seen that was presented already, what we know works. We developed panels, include scheduled acetaminophen, NSAIDs, and then oral opioids and IV opioids for rescue, had them approved at all these various levels, and implemented them. So we implemented them into all of the ERAS, the Enhanced Recovery After Surgery, Alberta Post-Procedure Order sets available, and now we are going from one surgery council to another, urology, general surgery, orthopedics, there's a lot of them, to get them approved by every single area council so that they can also be included in those order sets. So far, this has been applied to over 500 patients with 256 providers. Third objective. This was our focus on digital health technology. We know that this is a huge population. It's hard, it's been mentioned multiple times today, but it's really hard to see patients one-on-one for all these issues. Can we use technology in a way that would be helpful within this population? We decided to reach out to the spine surgeons and see if we can have spine surgery patients and study the uptake of this application. We ended up recruiting 11 spine surgeons, half in Calgary, half in Edmonton, and we recruited 83 patients to the study. There I have the patient use before and after their surgery, and then the surgeon portal use as well. Overall, the patient experience survey was generally positive for the app. In terms of the key points of what we found from this piece of work, our uptake and engagement in the spine surgery population was quite variable, particularly after surgery. And really, I think where we had difficulty in this objective was in the implementation phase. We had a lot of difficulty with implementation with the surgeons, and we had even more difficulty with implementation with their MOAs. So we did our best. We did recruit patients. The patients that used it, definitely there was benefit there, but we did feel like our uptake was fairly low. So some things to think about for the future are that I think we need to clearly identify the information support needs of the patient, staff, and the local system and their milieu. We are also dealing with sort of individual surgeons' offices that were not located within the hospital. We need to understand the fit of the proposed digital tools in the particular clinical context and identify barriers to technology adoption and see if we can mitigate that. And the fourth objective of our grant was to really try and develop a bit of a blueprint for how we could spread and scale transitional pain services within our province. We had one provincial health system, which was Alberta Health Services, which is soon to be 4 pillars across the province. Additionally, with 51 contracts with non-hospital surgical facilities. In 2022-23, we did 286,000 surgeries, which is just down from our usual, which is typically just under 300,000 surgeries a year. And this includes 100,000 inpatients and 186,000 day surgeries. So if we do about 300,000 surgeries per year, and we'll say a conservative rate of 10% of these individuals develop CPSP, that's 30,000 new cases of chronic pain per year. So really the problem is in Alberta, transitional pain care is very limited. There's gaps in care transitions, huge gaps in care transitions, which disproportionately affect patients at risk of health inequity, including those living in remote and rural areas and Indigenous communities specifically. A solution to increase the availability and access to TPS is to offer it virtually. We are proposing the development of a virtual surgical transitional pain service with the goal of decreasing the number of people who transition from acute to chronic pain and address problematic opioid use. And the goal of this work is to provide evidence-based integrated care throughout the surgical journey from the medical home and the community back to the hospital and inpatient setting and back home. This model would include multimodal pharmacologic approaches to pain management, biopsychosocial approaches, opioid weaning interventions when it was indicated, psychosocial, psychological interventions using a collaborative care model. And we already have the development of a virtual chronic pain program within our province, and we would work closely with them, use the infrastructure that's already existing and being developed to build a virtual TPS program. We'd like to use a pre-surgery screening tool to screen patients that are at highest risk of having poor outcomes. Employ nurse practitioners as navigators throughout this transition and use virtual resources. From a practical standpoint, where are we in terms of rolling out TPS within our province? We've had a transitional pain service at the hospital. It's pictured in the top there in the southern part of Calgary for quite a few years now. It does a great job, and it serves kind of that population in the southern part of Calgary. At my home at the Alberta Children's Hospital, we have started a transitional pain service in November of 2022. We affectionately call it the bridging pain service because it bridges the gap between the acute and the chronic pain service. Our referrals are increasing, our population is increasing, and it's going very well. And then there is also the start of an adult transitional pain program in Calgary. It was just started last month. It's starting at the hospital in the Northeast at the Peter Lougheed, and the plan is to expand to the Foothills Hospital and Rocky View as well over the preceding 1 to 2 years. I'm going to leave it there, but I just want to take a minute. This was the first major grant that I was PI on, and I couldn't have done it without this absolutely fabulous, collaborative, super engaged team, and we did a lot of it over the pandemic, and this was every Monday morning at 9. But we had a really great time, and I think, I'm proud of the work that we were able to accomplish in 18 months. Thanks.